Good afternoon. So this will be a panel discussion on liver regeneration strategies in intervention radiology. So basically we'll be discussing about portal vein embolization. So our panel consists of Dr. Taraprasad Tripathy, Associate Professor and HOD in HOD Department of Surgical Gastro, Dr. Dayanand sir, Senior Consultant Intervention Radiologist from TMH. So partial hepatectomy is the standard of care for an increasing number of patients with hepatobiliary malignancies, and the resectability criteria demands a negative margin and sufficient future lever remnant volume. So I'll come to that terminology, future lever remnant volume. This is a term that we'll be frequently using throughout this discussion. And extended right hepatectomy has a high risk of post-op liver insufficiency, and smaller future lever remnant is the single most important predictor for complications after hepatectomy. So we'll cover the terminologies, indications, hepatectomy and associated morbidity and mortality, principles of liver regeneration, pre-op assessment using CT volumetry. So what is standardized future liver remnant, what is dynamic hypertrophy, what is kinetic growth rate. So these are certain terms we'll discuss in details. How is the procedure performed, what is the post-operative management, and regarding complete hepatic deprivation, and also about surgical approach of liver regeneration, that is ALPPS. So you can see this is a CT image, and the volumetry has been done by software known as Miriam. So after this is pre-procedure liver volumetry, you can see this is the resection plane, this is the right lobe, middle hepatic vein plane, and the left lobe. This was a case of cholangiocarcinoma, and had inadequate future liver remnant. So portal vein embolization was done. So after portal vein embolization, these are the glue casts within the portal vein, and the future liver remnant has been drained by a drainage tube, internal external drainage tube. So you can see the appreciable increase in the volume of the future liver remnant. So after hepatectomy, this is the remnant liver that is going to stay with the patient, that is going to do the liver functions in the patient after operation. So this is how a liver looks like in intra-op after portal vein embolization. This is the right lobe of liver which is atrophied, and this is the segment 4 and left lobe which is hypertrophied. Okay, so coming to terminologies, what is future liver remnant? So this is that part of the liver that is going to stay with the patient after the hepatectomy. So whatever is the kind of hepatectomy, the remnant liver that is going to stay with the patient is future liver remnant. And what is standardized future liver remnant? So this is future liver remnant volume calculated by CT. So you can calculate it by your routine CT softwares or dedicated softwares, liver segmentation softwares like Miriam, and is divided by the total estimated liver volume. The total estimated liver volume is calculated by a formula. This is a minus 794 plus 1267 plus body surface area. Body surface area calculated by standardized formulas. So for volume calculation, you can use a routine CT scan post-processing for volume calculation, or a more dedicated and accurate software called Miriam. Okay. So this volumetry has been done in Miriam software, where you can see the right lobe has been colored in the orange. And this is the one that is going to be removed from the patient's body after hepatectomy, and this is the middle hepatic vein plane, and this is the future liver remnant. So we'll come to the indications of portal vein embolization. I'll hand over the mic to Dr. Taraprasad Tripathy, MS MCH Surgical Gastro. I think we are only government setup at AIMS who are doing hepatectomies and in good numbers. So sir will take you through the indications of portal vein embolization. In which conditions does he refer the patients for portal vein embolizations?
Thank you, Tara. So when it comes to portal vein embolization, like in all liver resection cases, there has to be a very good coordination amongst the surgical gastroenterologist and IR. So first of all, we need to have a very good delineation of the anatomy, so that accordingly which type of liver resection we are planning, that we can know. So on CT, like Tara said, we can do the FLR, that is future liver remnant estimation, by manual. Like in conventional CT also there are inbuilt softwares to calculate liver volume, but these more sophisticated softwares like Miriam they are slightly more accurate, though the studies says that there is no difference between Marian and other softwares, but end of the day Marian software has got a higher accuracy. So once we know the FLR is less, then that becomes the first indication for portal vein embolization, and most of the time it is a right portal vein embolization, because the way the volume distribution of the liver, around 50 to 60% of the roughly around 60% of the liver belongs to right lobe, and around 30 to 40% is left lobe. So in left hepatectomy, most of the time the portal vein embolization is not required because FLR is adequate. But in right, or specifically in right extended or modified right extended liver resections, the portal vein embolization is very much indicated. And one more thing which he has very rightly highlighted, apart from the type of liver resection, the background of the patient, clinical background of the patient is also extremely crucial. Like patients having comorbidities, specifically diabetes, they have a slow rate of liver regeneration post surgery. So in those cases also we take a higher FLR, estimated higher FLR is more. In cases where the background liver parenchyma is compromised, like any hepatitis B or C infection, though they are not cirrhotic, but you expect some amount of fibrosis there, then in those cases also we take it as a 40%. And in a child age cirrhosis also the minimum is 50%. So it doesn't only depend on the type of liver resection, but also depend upon the background parenchyma and the background clinical profile of the patient as well.
I'll request sir to take us through hepatectomies. What are the different types and the mortality and morbidities associated with the hepatectomy?
The morbidities and mortalities concerned to hepatectomy has improved quite a lot for the last 2 decades, all because of more and more experience and more gadgets being used in liver surgery. So hepatectomies, practically these are the common hepatectomies are left lateral, that is removal of segment 2 and 3, that is to the left of falciform ligament, and then right hepatectomy, in which segment 5, 6, 7 and 8, 4 segments are removed, and then extended right, in which 4A, 4B, 5, 6 and 7, 8 along with plus or minus chordate. It depends upon the indication of doing a right extended hepatectomy. Like for SCC, the right extended is enough, but for all hilar cholangiocarcinoma, we need to take out chordate, that is segment 1. So these are, apart from that, left hepatectomy is also. In left hepatectomy, we need to take out 4, 5, 6, 4A, 4B and 2 and 3 plus minus chordate depending upon the indication of hepatectomy. And in gallbladder cancer with segment 4B and 5 involvement, many a times a extended wedge resection of liver is sufficient, but at times a central hepatectomy is indicated. Central hepatectomy means we need to take out both sides of the MHB, that is 4A, 4B, 5 and 8. So these are the more common types of hepatectomy.
Okay, sir. So now we understand what is the indication for portal vein embolization, and we understand what is hepatectomy, what are the different types, and what are the morbidity and mortality associated with hepatectomy. And also we will learn that as the fibrosis grade increases or the background liver changes increases, the mortality associated with a resection also increases, as pointed out by sir. So the perioperative complications, the single most important predictor is future liver remnant. I think that is the most important thing that we should focus on, despite along with background liver parenchyma. What is the future liver remnant? That will decide the overall morbidity, be it pulmonary, biliary or hemorrhage, as you see in this curve. So what is a small for size liver? Yes.
Okay. So small for size liver, suppose this we call it as a small for size syndrome, rather SFSS. So it mostly belongs to in the settings of liver transplantation. But in case of liver resections also, suppose your FLR is inadequate and you have done a hepatectomy without calculating the volume preoperatively, then you will end up in small for size syndrome or small for size liver. What happens is that the amount of portal blood flow to the liver remains the same, but the liver decreases in size after hepatectomy, and that much of small liver, and if at all it is compromised like background fibrosis or something like that, then this small compromised liver takes the whole load of the high portal pressure and high portal flow, and that leads on to small for size syndrome, and it suddenly the post-operatively, clinically it manifests as a deranged liver function and ascites. It's like I told you, it is most common in liver transplant settings, very common scenario if the graft size is small, and then portal pressure increases, and end of the day they have a very stormy post-operative course, and the patient may have to face a mortality as well.
So what are the guidelines for resection? So the guidelines for resection say that the sFLR has to be 20% in normal liver, 30% in injured liver, and 40% in liver disease. We'll come to it in details. This is the future liver remnant volume that should be there for a safe resection. That means to have least complications post hepatectomy. So what are our preoperative strategies? So what we do is we do portal vein embolization. This redirects the blood flow towards the future liver remnant. It initiates the hypertrophy of the non-embolized segments, decreases the perioperative complication, and increases the potential candidates with marginal anticipated FLR volumes, or the future liver remnant volumes were earlier not candidates for surgery, now becoming surgical candidates. So it's a boon for those patients, those group of patients with an inadequate future liver remnant. Okay, so I'll come to the liver regeneration. This was to be covered by Hemant sir, but he has some urgent commitments. So atrophy hypertrophy complex. So the part of the liver that is going to be removed undergoes atrophy, and the part of the liver that is going to stay within the patient is undergoing hypertrophy. So what it does is, as we do the embolization, there is apoptosis of the cells. So when you do a TACE, like for HCC, you are doing necrosis, whereas when you are doing portal vein embolization, you are doing the cell death is via apoptosis mechanism. So this releases several factors, and the most important factor among it is hepatocyte growth factor, and this hepatocyte growth factor that is released will help in regeneration of livers, of the remnant liver. So there are certain studies that were done which shows that the post portal vein embolization of the right portal vein, it will direct the bile flow, blood flow, portal flow towards the non-embolized lobe, and there are less alteration in LFTs or liver function test after resection following PV. So there are several meta-analyses that have supported the portal vein embolization. So how it is performed, the earliest description was by Makuchi, where he did a lap and accessed the SMV, and through that he placed a sheath and then did embolization. We have it was way back in 1990, and thereafter the techniques have improved, and we do in certain way that we will be explaining. So this is basically the illustrative picture. Stage 1, what we do is we embolize. These are the tumor in the right lobe. We embolize this right lobe. After a few days, that is 4 weeks, it takes for liver hypertrophy. The remnant liver hypertrophies, and the stage 2 is surgical removal of the right lobe. So I'll just take you through one case. This was a case of neuroendocrine tumor, 56-year-old female, CAGB, inadequate future liver remnant. So this is how we do the Merian volumetry. You can see there are 3 colors. This is the tumoral color in pink. This is the right lobe that is going to be resected in green, and this is the future liver remnant in orange. So the sFLR we calculated by dividing it with the TELV, it came out to be 17%. So it was considered inadequate and was referred for portal vein embolization. Patient had received chemotherapy. So you can see this is the coronal MEP images, where you can see the portal vein, right portal vein, left portal vein and its branches, and this is the tumor. So in this case, since there was a large tumor on the right side, we are unable to access the right side. We approached through the left side. So there are 2 approaches. You can approach through the right lobe of the liver to embolize the right lobe, or you can approach through the left lobe of the liver to embolize the right lobe. So here what we did is punctured a peripheral portal vein branch. This is a sheath that has been placed, which give us continuous access into the portal venous circulation, and we have placed a KMP catheter and taken a run. So in this run you can clearly see the main portal vein, the right portal vein and its branches, the left portal vein and its branches. Okay, so thereafter what we do is we selectively go into the individual segmental branches. So it is a run from one segment, and then we inject glue. We use 20 to 30% glue. We mix the glue with lipiodol, make it 20 to 30% mixture, and start injecting. Similarly, we go to the next segment, take small aliquots of glue and inject. So these are the glue casts previously done. This is the new glue cast. You can see the glue cast moving around from the center to the periphery. That is the direction in which the portal vein flows. So after completely embolizing the segment, this is the final run. As you can see in the final run, the entire portal venous circulation has been now diverted towards the left lobe. So this is the final fluoroscopic spot. You can see the segments have been completely embolized by lipidol glue cast, and this is the remnant left lobe. On a CT you can better appreciate, those who are reading the abdominal CTs regularly, this is the right lobe with lipidol glue cast. The left lobe has been spared from the glue casts, and this is the large neuroendocrine tumor. So subsequently this patient underwent at 4 weeks we did the repeat scan and the liver volumetry. There was 6% increase in sFLR. It was not adequate. There are several reasons why it was not adequate. We will go into that discussion. So there are certain malignancies. We are basically dealing with 4 malignancies while doing portal vein embolization. One is HCC patient who is to undergo a right lobe resection with an inadequate FLR, or a carcinoma GB patient, or a cholangiocarcinoma patient, or a metastatic colorectal cancer, or for this case, last case we described was a neuroendocrine tumor. So my question to Dayanand sir will be, so which of the malignancies require a systemic chemotherapy, which of these require a localized chemotherapy, and what are the agents that can cause chemotherapy associated liver injury, and in those situations what we should do?
Actually the carcinoma gallbladder, which actually they progress very fast. So if you are doing because the from the portal embolization to the surgery, it almost takes minimum almost like a maybe 1 or 8 weeks to somewhere that range in our hospital. So for a carcinoma gallbladder, this is too long time. So I think for if you are doing a carcinoma gallbladder, I think you require some kind of chemotherapy. But other things, like if you are doing for SCC and all, probably you can just manage with a portal embolization and you can wait.
Okay, sir. Thank you, sir. So we'll take another case. So this was a 56-year-old female, carcinoma GB, adenoCA with inadequate FLR. sFLR was 24%. Since this patient had received chemotherapy, so considering marginal liver, was referred for portal vein embolization. So this is how you see it on a Miriam software after doing the segmentation or volumetry. This is the right lobe that is going to be removed. This is the tumoral part, and this is the left lobe, and these are the hepatic veins in green. So in this case what we did is we did a ipsilateral approach. So we'll come to that discussion later. So you can see now we have punctured the peripheral portal vein with the micropuncture set and injecting contrast. So you see the contrast is going to periphery. So if it would have been a biliary puncture, it will go to the center. A portal vein puncture will go to the periphery. So now we are into the portal vein. So what we do next is place a sheath that will give us a continuous access into the portal vein, place a KMP catheter over a guide wire and take runs. As you can see in this run, we are clearly identifying the main portal vein, right portal vein and its branches, and the left portal vein. So similarly we go ahead and do embolizations. In the previous case we were coming from the left side. In this case we are coming from the right side. We started doing the glue embolization like in the previous case. And this is the final fluoroscopic spot with the right lobe completely embolized and the left lobe left behind. And you can see we have drained the future liver remnant. So we'll come to it why we need to drain the future liver remnant later on. So 4 weeks later there was an increase in sFLR to 41%. Unfortunately during surgery this patient had omental deposit. That is what sir was telling. CAGP patients are unfortunate to present with omental or distant metastasis during the course of the disease. So this patient's liver hypertrophy was adequate. However, the omental deposits during the period of that portal vein embolization, when we followed up the patient, she developed omental metastasis. Okay, so this is the Miriam volumetry image. You can see the right lobe is shrunken and the left lobe is relatively hypertrophied. So draining the biliary system of FLR. I'll ask Dayanand sir to take us through what is the importance of draining and why we should drain the future liver remnant.
Draining will help to reduce the infection. That is very important because patient waiting period is too long. And another thing is it also aids to the hypertrophy of the future liver remnant. So that's why it both way it will actually sometimes we train the same side also if, to prevent infection. So
sir, our target is always less than 3. What you follow, sir? Less than 3 or less than 5? The bilirubin level. Bilirubin level.
Bilirubin, they are I think 5. They are good enough as long as other parameters are okay.
So what we were discussing is in carcinoma GB patients and hierarchical angiocarcinoma patients, they have elevated bilirubin levels. So first we drain the future liver remnant and bring the bilirubin down to less than 3. Then go ahead with the portal vein embolization, so that there is adequate hypertrophy. Higher bilirubin level prevents the adequate hypertrophy of liver, the future liver remnant. So I'll also ask sir to take us through contralateral versus ipsilateral approach, which approach is favorable in his practice, and what is the advantage and disadvantage. We have seen 2 cases, one we did contralateral, one we did ipsilateral. Please, sir.
The ipsilateral approach is good for the patient because we are not touching the future liver remnant. Contralateral approach is good for the doctors because it is easy to manipulate. So because we are patient first, we always take ipsilateral approach. Contralateral approach is very rare. There are advantage of contralateral approach is like you will easily manipulate. You come from opposite side, you can easily go to each segment and do it. And also we can get a very nice angiogram after the procedure. We can keep the catheter and get a nice angiogram, prove it. But problem is like especially when if you are using the contralateral approach for a glue injection, it is you should be very extremely careful. If a glue stuck to your this thing, if and it is attached to whole cast, whole thing will come to the left side and patient will jeopardize the future the surgeries. Ipsilateral approach, it's like a very I always take ipsilateral approach. Only thing is it's difficult to go into each segment, but it's but only thing that is but you use the different curvature. You have you can put a sheath and you can use keep changing the catheter if it is catheter is occluding. That gives the option, and you will with experience actually you get to occlude completely.
So for people practicing IR, I think if you are taking ipsilateral approach, have a KMP in hand and have a rim catheter in hand. Rim is very useful for cannulating the branches from the ipsilateral side, and you can almost complete your procedure using only rim.
And the coil you cannot use it as ipsilateral approach. Very dangerous if you want to use the coils or something proximal occlusion devices. I think contralateral approach is better.
Okay, sir. Thank you, sir. Sir, you also take us through the embolizing. There are several embolizing agents. People have used different embolizing agents for embolizing the portal vein. We have shown you a glue for embolization. So please take us through various agents and what are the advantages.
So many agents are used like a gelatin sponge. These are a temporary agent, and the other more permanent particles are like PVA particles, fibrin glue, and the glue. And ethanol is a liquid embolic agent, and like recent embolic agents are like EVOH. So to get a best results, you have to occlude as distally as possible. So that you prevent the collateral circulation. You know that the blood can, if you want to occlude the proximally, blood can come from the arterial side, blood can come from contralateral venous side. So many things can happen. So to get a best result, you have to occlude as distally as possible. That is possible with a glue, liquid embolic agents only. So that is the reason the liquid embolic agents are the best agents, and they give a best hypertrophy as compared to other. People have used gelatin sponge and other things, but they don't give so much of good hypertrophy as compared to other agents. So my favorite is always glue. Ethanol require anesthesia, so that's why very painful procedure, and we don't have very proper control, so I don't use. But glue is I think my favorite, and I think it's the best agent for a good hypertrophy.
So the best agent for hypertrophy in I think RCTs that have been published for embolizing agents in PVE is glue, as sir told, and in an experienced hand it is cheap and the best and gives the best result. So coming to case 3, this is a case taken from Amar sir. So this was a 57-year-old male, carcinoma GB with infiltration into CHD and lesion abutting RHA. Patient was posted for right hepatectomy. Problem was inadequate FLR and raised bilirubin, and the plan was right PVE. So PTBD was done. Bilirubin level was brought down to less than 5, and you can see this coronal image showing dilated biliary system and the mass in the hilar region, and this is the portal venous anatomy you are able to see on axial and coronal. This is the main portal vein, left and right portal vein, and as you see in the previous image, here also you are able to see the portal venous anatomy. Then we go ahead and embolize individual segments as we have seen earlier. So what I want to show here is, after completing the distal embolization through these are the glue casts, what we have done is placed a plug. So this plug, see, has been placed in the right portal vein. Contrast run has been taken. We are confirming the position that it has to be in the right portal vein, and there has to be some stump of right portal vein left for resection. After that, the plug has been deployed. So what is the purpose of a vascular plug in the right portal vein? Is it does proximal embolization. So we have achieved distal embolization adequately, and it is enough if you have adequately embolized with using glue, but a vascular plug will add to your embolization efficacy, and it has been shown that plug plus glue embolization, or doing a proximal plus a distal embolization, can achieve better hypertrophy of the future liver remnant.
When I speak to surgeons, actually they want a 1 centimeter of the proximal the portal vein to be patent.
Yes, sir.
So that will maybe problematic if you use the plug.
Sir, I think sir has a series of patients with this thing. It has not been published, where we leave a stump of 1 centimeter prior to placement of vascular plug, then it is embolized. So I think sir will come up with this paper very soon. Anything you want to add, sir?
In this kind of scenarios, is very important to delineate the portal venous anatomy, whether it is type A, B or C. Like in this patient, this is a type A portal vein anatomy. Again, in subsets of type A portal venous anatomy, what sir was asking, was trying to tell is that you need to measure the whole length of common right portal vein. If the common stump of right portal vein is less than a centimeter, then using a plug would be very difficult for us during intraoperative division of the portal vein, whether using clips or maybe sutures, or maybe using staplers also, vascular staplers. But if the common length, like in this cases, the right portal vein is quite long, it is looking like some 2.5 centimeter. In these kind of patients, it should not be an issue.
So as sir was telling that portal venous anatomy and its variant, you should know regarding the variants. This is the type A, where the main portal vein divides into left and right portal vein, and right portal vein further divides into right anterior and right posterior. And this is the trifurcation variant, or a type B, where the main portal vein trifurcates into right anterior, right posterior and left portal vein. This anatomy is very important to know prior to embolization. Again, this is type C, where the right portal vein originates from the main portal vein, and you can have certain uncommon variants like this left portal vein meandering into the left lobe. So just to show you the variants, since we are discussing it, then we come to segment 4 embolization. So you can see this is segment 4, and it has been shown that embolizing segment 4 in case of extended hepatectomy will achieve better hypertrophy of the left lobe of liver. Okay, so what we have discussed is why we are able to do a portal vein embolization. This is because liver has a high regenerative capability. Following portal vein embolization, the total function of the liver is progressively accelerated towards the future liver remnant, and making the patient suitable to adjust the modification of portal pressure before the surgery. After portal vein embolization, compensatory hypertrophy of the contralateral and atrophy of the embolized lobe occurs, and right portal vein embolization facilitates safe extended right hepatectomy, typically after 3 to 6 weeks. So low complication and good proliferation rates make portal vein embolization the therapy of choice in those subset of patients with an inadequate future liver remnant. So coming to the CT volumetry, as we were discussing earlier, so this is how we measure the CT volume. We know what is standardized FLR. So you measure the liver volume divided by total liver volume. Then coming to degree of hypertrophy. So what is degree of hypertrophy? It is the volume of the future liver remnant after embolization, portal vein embolization, minus before embolization. So suppose the sFLR is 30% after embolization, and it is prior, it is 17, so degree of hypertrophy is 13%. So only sFLR, the degree of hypertrophy is a better predictor than standardized FLR for predicting the complication rates. As you can see in this study, they have shown that degree of hypertrophy is a better predictor of predicting the complications. So after degree of hypertrophy, what they have done is calculated the kinetic growth rate. So this is the best indicator of your hypertrophy, liver hypertrophy. So what is kinetic growth rate? We are giving 4 weeks for the liver to regenerate. So suppose patient is having 8% increase in the 8% increase in liver volume, or degree of hypertrophy is 8, we divide it by 4 weeks, that is 4. So the kinetic growth rate is 2. So for kinetic growth rate, it has to be more than 2% for a good for predicting less complication post portal vein embolization. So this is what we have discussed earlier. So sFLR, if it is less than 20%, FLR is less than 30% in diffuse parenchymal disease, that is non-cirrhotic patient with chemotherapy associated steatohepatitis, and FLR of less than 40% is cirrhotic livers, we should undergo a portal vein embolization. And if the degree of hypertrophy is more than 5% and kinetic growth rate is more than 2%, the incidence of post hepatectomy liver failure will be less. So there are certain contraindications, that is established portal hypertension and widespread portal vein thrombosis. Relative contraindication, we leave it. So pre-op assessment, we do multidisciplinary team discussion. Complete history and examination is taken. The CBC, LFT, bilirubin levels are seen. Pre-operative imaging is of very important in planning the case. See the extent of disease, whether it is resectable or not, and see the portal vein anatomy. As we have covered the anatomy already, we will skip this. And what is the post-op care? So what happens is, as we have discussed, the cell death mechanism is apoptosis. So when there is apoptosis, there is not much post-embolization syndrome associated with this patient. In fact, in the West, these patients are being discharged in the same day, in day care basis. So surgical resection, then patient will undergo surgical resection if there is adequate FLR hypertrophy. Okay. So the perioperative outcomes after PV are usually good. So we'll skip this. So I'll come to next topic. In HCC patients who are to undergo resection and have an inadequate FLR. So shall we, suppose in this case there is a arterial enhancing lesion, intralesional fat, diagnostic of HCC, 40-year-old male, Hep B positive, cirrhotic. So what we should do? We should do TACE, then do portal vein embolization, then do resection, or since there is we are already will be resecting it, so directly go for portal vein embolization, achieve hypertrophy and directly undergo resection. So there are two options. So studies have shown that if you do a TACE first, then do a portal vein embolization, then do a resection, then the results are good, or hypertrophy is adequate. So the regenerative capacity after portal vein embolization, resection may be impaired if you have a HCC that has not been treated. So you have to achieve a local tumoral control. HCC has to be controlled first using TACE, followed by that portal vein embolization has to be done. So these are the papers that have supported TACE plus PVE in HCC patients to have overall better disease-free survival rates.
Other thing we can do is the tear.
Yes, sir, definitely. Sir discussed today morning. I have excluded a slide. Radiation hepatectomy you can do. Once you give radiation, the right lobe will undergo, it will shrunk in size, left lobe will undergo hypertrophy, then surgeries can be done. So just I'll show this case where the case that we have CT image that had shown this patient. We did transradial TACE. You can see this HCC here, the tumoral feeders. We did a good embolization. This is the lipidol cast. Thereafter patient underwent portal vein embolization, and thereafter achieved a good hypertrophy of liver post procedure. So there are certain alternatives. I'll skip this. I'll come to what is total hepatic deprivation. So we are closing only the portal vein. Suppose we don't achieve adequate hypertrophy, we can go ahead and block the hepatic vein. So in Eastern groups like Japan and Korea, they do hepatic vein embolization in patients who do not have a adequate hypertrophy of liver after portal vein embolization. And total liver, the concept of total liver venous deprivation, you deprive the liver of all the venous channels, that is portal vein as well as hepatic vein. This achieves faster FLR hypertrophy. So we'll be concluding that after discussing regarding the ALPPSL, I'll ask Dr. Patnaik sir to take us through what is ALPPSL and where it stands against PVE.
The ALPPS is associating liver partition in addition to a portal vein ligation intraoperatively. So in portal vein embolization, we are just embolizing the right portal vein. In ALPPS, what we do after ligating the right portal vein intraoperatively, we transect the liver as a whole as well. So what happens, the minute portal venous connections between the left and right lobe, that is also taken care of, so that no blood from the blood which is flowing from main portal vein to the left portal vein, it doesn't come to the right side at all. But on reality, the indication of doing ALPS as of today is very debatable and very subjective. Like centers who do routine ALPS, they'll just do portal vein embolization, and if there is no adequate FLR, they'll go and do an ALPS. The Western data, it favors ALPS a lot, because in the Western side there's a lot of CRLM, there's a colorectal liver metastasis, in which the ALPS is much more indicated compared to SCC and hilar cholangiocarcinomas. But again, in the centers in which I have worked like you and me, we are there in ALPPS, we have never done a ALPS, because the indication for ALPS is very, very limited on a practical perspective. But surgeons who prefer doing ALPS, they'll have a low threshold of going in, and those like we do not prefer ALPS, so obviously we'll be needing a hepatic venous embolization in addition to portal vein embolization if the FLR is inadequate. So the indication of ALPS is very, very subjective, and it is limited to some of the geographical regions.
Highly morbid procedure, that's why they
the high volume centers, they claim the morbidity is not that much, but again it is not reproducible properly, and many criticize the data, the way the data are published, like the morbidity is only 20% and mortality less than 2-3%. But many of the centers, they do not follow ALPS, except some few Western lit hospitals.
Thank you, sir. So I'll just conclude to what we have discussed. We'll first assess for FLR or future liver remnant adequacy. So what is the minimal FLR volume required for that patient? Then induction of hypertrophy of liver, whether patients should undergo a portal vein embolization or ALPS procedure. Then for major hepatectomy, we have to address the cases on case-to-case basis, like for whether the patient is having hepatocellular carcinoma, background cirrhosis, a biliary tract cancer, whether biliary drainage is required or not, whether he is having cholangitis, or a patient of colorectal liver metastasis, because these patients have long duration chemotherapy given to them, so they will be having chemotherapy induced liver injury. And then comes the outcomes like the morbidity and mortality, post hepatectomy liver failure, and long term survival. So what we have discussed is regarding the indication of portal vein embolization, how we do it, and what are the outcomes. So I think we'll end the discussion here. Thank you.